risk of HIV/AIDS infection.
Thank you, Lisa. And I'd like to start by thanking the scientific committee at the conference for the opportunity to present this research, and also to thank my co-authors at the BC Centre for Excellence in HIV and AIDS who are listed here. I'll be presenting on some research around the social and socioeconomic benefits of antiretroviral therapy adherence among HIV-infected people who use illicit drugs here in Vancouver. I'd like to start by declaring that I have no conflicts. By way of background, I don't think it needs to be reiterated here the significant clinical benefits of ART adherence for people living with HIV/AIDS, ranging from the direct clinical impacts on viral load, stalled disease progression, individuals' reduced likelihood of having comorbidities, and extended life expectancy. And I think here at the conference, we've also seen now with the results of HPTN-052 that there is very strong evidence for the sustained and significant population-level decreases in onward HIV transmission from ART scale-up immediately after diagnosis and across populations. And among people who use injection drugs who are adherent to ART, they enjoy analogous benefits as the general population. What we know less about are the secondary clinical and non-clinical benefits of ART. There's been a sizable body of research looking at the physical and mental health quality of life benefits of ART, and some research related to the uptake of OST, or substitution therapy, opioid substitution therapy. However, this is a really limited number of secondary outcomes, and the main objective of this study was to examine whether becoming optimally adherent to ART is associated with improvements in a range of social, socioeconomic, and secondary clinical outcomes among people who use illicit drugs. Brendan very kindly introduced the study whose data is used for this analysis, so I won't, in the interest of time, go into an extensive amount of detail here. But to briefly remind everyone, the AIDS Care Cohort to Evaluate Exposure to Survival Services, or ACCESS study, is an ongoing community-based cohort based out of Vancouver that enjoys data linkages to participants' complete retrospective and prospective HIV clinical profiles. That includes all viral load measurements, all ART dispensation information, and that's provided through the BC Centre for Excellence in HIV/AIDS drug treatment program. I'm briefly going to mention the methods that I used here. I won't go into them in a lot of detail, although if people are curious, I'm happy to provide further explanation. Each model was a generalized linear mixed effects model across a range of different social, socioeconomic, and secondary clinical outcomes that used a backwards model selection procedure with adjustment for known and hypothesized confounders. A brief moment about the different outcomes and measures that we used for the study. Each model that we developed, and we developed a series of 5 different multivariate models across different outcomes, had as its principal covariate of interest becoming newly adherent to ART. So greater than 95% of their possible dispensation, of ART dispensation was recorded in the drug treatment program. And we wanted to examine a range of social and socioeconomic indicators. The first one that we looked at was whether or not people went from being not employed to being employed. And there's a range of literature and a growing body of literature about the barriers to employment among people who inject drugs and people who use illicit drugs. And that was our first outcome of interest. The second outcome that we looked at was whether or not individuals stopped their involvement in prohibited income generation. And prohibited income generation in this analysis included sex work, drug dealing, acquisitive criminal activity, as well as street-based income generation. That included panhandling, individuals who were binning or who return recyclables for money or sell goods that other people have disposed of, as well as squeegeeing or window washing in traffic. We also looked at individuals who transitioned out of homelessness, so people who report being homeless at one time period and then report having stable housing in the subsequent time period. We looked at intimate relationship initiation, and there's an extensive literature on the challenges of managing intimate partnerships in the context of an HIV infection, as well as addiction treatment enrollment. And while Dr. Boranasek yesterday presented an excellent paper on the complementarities between opioid substitution therapy and antiretroviral therapy, here our addiction treatment measure also included things like detox or outpatient services or attending Narcotics Anonymous meetings. And so we looked in each case at whether or not newly achieving adherence was associated with one of the transitions described here. So there was a separate model developed for each transition. Very briefly, the baseline characteristics of the sample, we had 724 HIV-positive and ART-exposed individuals who used illicit drugs in the study. Of these, 33.3% were female, and 55.8% reported Caucasian ethnicity or racial background. And individuals who were younger, who had a lower CD4 cell count at baseline and a higher viral load at baseline were more likely to become ART adherent over the course of the study. This figure shows the multivariate results for each model, and each of those horizontal lines is the adjusted odds ratio at the point and the confidence interval for becoming ART adherent, and whether it is related significantly to the outcomes that we examined that are listed down the left-hand side of the slide. And there are two results that I'd like to emphasize in particular. The first is that becoming newly adherent to ART was associated with stopping involvement in prohibited and illegal income generation. The second result I'd like to highlight is that ART adherence was associated with transitioning out of homelessness. And these models were all adjusted for relevant confounders, including socio-demographic characteristics, drug use variables, and various other indicators of risk for ART non-adherence. So what does this tell us? It tells us that ART adherence increases the likelihood of an individual reducing their socioeconomic vulnerability in another domain, and specifically around involvement in high-risk income generation and in transitioning out of homelessness. And we know that both of these things are associated with increased vulnerability to things like violence or incarceration, which have their own extensive literatures in terms of their relationship with HIV clinical outcomes and generalized well-being among people who use illicit drugs. So what does this mean? It means that, the implications of this are that individuals who improve their socioeconomic well-being, that improvement can reinforce engagement in HIV care, quality of life, and individual health outcomes. And the implications of this, I think, are that while ART adherence is really, primarily about the management of HIV infection at the individual and population levels, that there are also non-clinical factors that play into this and non-clinical domains in which ART can have a significant and measured improvement. And I think that this really supports calls for early ART uptake for all individuals, including people who use illicit drugs and people regardless of CD4 count, in support of UNAIDS 90 targets. I'd like to thank all of the research participants in particular, as well as the co-investigators and the research team at the BC CFE and funders that supported this research. Thank you.
Thanks, Lindsay. Great presentation. We've got a few minutes for questions, so please go ahead.
I'm going to be from the University of Toronto. Thanks very much. I know you said you used a linear mixed effects model, but it wasn't entirely clear to me whether you looked at adherence as a time-varying covariate or whether you just looked at whether they developed adherence at all over the course of the study period. And I think it's particularly important when we're trying to interpret the results because, you know, if homelessness and adherence are associated, is it that adherent people become are able to get housing, or is it that provision of housing actually improves adherence? I think there's a causation issue here.
Right. Thank you for the question. We did treat adherence as a time-varying covariate, and it was coded as a binary variable that every time adherence was achieved, that was counted as an indicator of our primary covariate of interest. I do agree that further research is required to really unpack the causal relationship between ART adherence and the outcomes that we were looking at. At this time, all I can say is that they're associated with each other and that there's a possibility of benefit, but we'll need to engage in different kinds of modeling to unpack that a little bit further. Thank you.
Dr. Friedman.
Yeah, I love it. It's imaginative, it's creative, and I don't believe the causal inference. Now, this is the problem, I think, in part, is that you're using a cohort study that was not designed to study these issues, so that you don't really have a lot of the potential confounding predictors. Because the question I have in my mind is what causes the people to become adherent, and whether that is also causing the people to have all these other benefits. You know, a standard problem in cohort studies and stuff like that. So what I would like to suggest, Vicky, since you obviously agree more research is needed, is that if you can organize a qualitative research study in which you're able to investigate those things very specifically and sensitively, we might actually discover some terrifically important stuff about how to improve the lives of infected drug users. So I just want to applaud you for opening up this very important area of research, which may keep you busy for half your career.
Thank you, Sam.
Hi, I'm Kara Moody from Oak Tree Clinic. I just wondered if you found in your conclusions any gender differences.
No, we didn't find any gender differences across any of the variables. We also, however, I would qualify, didn't conduct stratified analyses, and so those might provide further insight into whether or not there are any gender dynamics operating here. Thanks for the question.
Hi, thanks. It's Julie from Vancouver. So I'm just wondering here, with this, we know that people living in the downtown east side and people that are attached to a lot of these studies are very heavily engaged in community supports and care. So I'm just wondering if you looked at, were people who became adherent, were they engaged in primary care services prior to ARV initiation, or was that, could you tease that out at all?
Unfortunately, it's a data limitation where we don't have their comprehensive healthcare service utilization records. We only have their HIV-specific records, and so in this context, we haven't teased that out. But it is also, I think, a really fruitful area for future research.
Yeah, I think it just kind of, I agree with the comment that, you know, these kind of things happen, and whether it's, you know, the chicken or the egg, I guess, you have to look at who's supporting who, and does that come along with antiretroviral treatment? Well, we know it does, yeah.
Right.
Thanks.
Thank you.
Kim Page, University of New Mexico. First of all, I love prospective cohort studies for their valuable, systematic, longitudinal data. In this regard, I commend you. And just, you know, I think that we can't ignore when we have this kind of data collected over time and the excellent work you've done. But unpacking that issue around drug treatment is a concern in this analysis. You have a polydrug use epidemic in this context with different types of drugs and different types of drug treatment. And that concerned me the most about this analysis, because you can't put NA for, you can't join up NA with methadone treatment in the same analysis. And so I would just suggest unpacking that a little bit if you want to look at that outcome. But, because that was the one that I had the most trouble with. And you've got, there is no medically assisted treatment for cocaine, but you have a big cocaine and crack epidemic. So you need to unpack that and then also look at the type of drug people are using on how that impacts this too. Because it's such a rich data set, and I commend you for drilling into it.
Thank you.
Great. Thanks again, Lindsay.